They've been involved actively in various pediatric meetings around the country. And he has a huge experience in pediatric orthopedics, in trauma. There's almost no case that you show that he hasn't seen something similar in his own practice. So it's always a pleasure to have him with us. And I'm sure you will learn a lot from his experience. So over to you, PN, Dr. PN Gupta, and we look forward to listening to you.
Thanks, Dr. John. So should we start?
Yeah, we are ready to start.
Yes, please, sir.
So is my screen visible?
Yes, sir.
Am I
Yes.
audible clearly?
Yes.
Yes.
Do we have some residents on the thing here?
Yes, sir. We have, sir.
There are
I
5 or
think
6 of them already there.
We can have interaction. So this is
Sure.
I'll start with the case. This is a 35 years old man. He has pain on activity in the right hip for the past 2 years. The treating physician did the examination, could not find any fixed flexion deformity. The range of motion was full. There was no tenderness. The limb length was equal. He's an occasional alcoholic in the history. There is no treatment suggestive of corticosteroid intake. The physician had no clue to the diagnosis, so he ordered an MRI, which classically, if you see what is taught in the PG teaching is AVN, osteoarthritis, tuberculosis, and inflammatory arthropathy, and none of them was picked up on the MRI. And then he was like sort of clueless what is the diagnosis. So it was labeled as fibromyalgia by the treating physician. And similarly, we have this case you have already seen. We have this case presenting with hip pain with not much remarkable findings. Similarly, this patient, this patient, this patient of different age group. This is a child aged around 16. This is a child aged around 10. This is a child aged around 9 or so. This is a 17 years old man. And this is again a 15 years old boy. 14 years old girl. Again having hip pain. So let's see what it is. So the topic today is a femoroacetabular impingement. And if you talk of impingement, impingement means intrusion into an area belonging to something else or somebody else. And the femoroacetabular impingement, if you see, is an impingement between the proximal femoral region and the acetabular region during the hip motion. And femoroacetabular impingement is identified one of the factors for early degenerative arthritis of the hip. So let us see what this femoroacetabular impingement is. So we'll be discussing about the types of impingement, the presentations, the radiology, the imaging, and the what is the management of this impingement. So we have extra-articular impingement and we have intra-articular impingement. In the extra-articular impingement, there could be a iliopsoas impingement, subspine where the anterior inferior iliac spine is impinging, ischiofemoral and greater trochanteric pelvic impingement. In the intra-articular, we have the CAM, we have the pincer, and we have the mixed type. That is a combination of the CAM and pincer. So let's first talk about extra-articular impingement. And the first is the iliopsoas impingement. And the iliopsoas, basically, it's the psoas tendon, which impinges on the anterior aspect of the hip during extension. And this type of impingement is very frequent in sports players. They usually present with hip or groin pain, which increases on walking or activity. And later on, patient may have difficulty in walking. Some of them will have a popping sensation. And some of them, they could feel weakness of hip flexors. And once you examination is very simple. Once you stress the iliopsoas by a passive extension of the hip, you find patient will have pain on passive extension of the hip. And similarly, if you ask the patient to do a active resisted SLR, this could be painful. However, most of the times it is the passive extension of the hip which is painful. And one can find tenderness at the anterior joint line in a lot of cases. If you see the radiographs, you will not find anything remarkable in the radiographs, but the diagnosis is clinched by the clinical examination, the presentation, and the MRI, which could show a little bit of edema there on the anterior aspect, and occasionally a labral tear at 3 o'clock position. And this labral tear could occur in long-standing cases. And once the labral tear occurs, this would be a precursor for early degenerative arthritis. What is the treatment? Well, always it is the non-operative treatment first with rest, analgesics, and some physiotherapy, including heat. But in case that does not solve the problem, and even activity modification sometimes helps to relieve the symptoms. But if that does not solve the problems, then one can consider psoas stenotomy, intramuscular psoas stenotomy at the level of labrum, which could be open or arthroscopic, repair of the labrum, which could be open or arthroscopic. Then the second subset is the subspine extraarticular impingement. And the subspine impingement is because of the prominent anterior inferior iliac spine, which abuts the femoral neck inflection. And where do you have this prominent anterior inferior iliac spine is because of the continuous traction on the anterior inferior iliac spine, which occurs especially in the young athletes which involve lot of kicking, running, where there is a little traction on the rectus femoris or overuse of the rectus femoris, especially seen in young football players. And there is an anterior hip pain which gets aggravated with running, kicking, and later on it could get aggravated with walking as well. Examination, well, again, if you sort of stress the anterior inferior like attachment of rectus, so passive flexion of the hip, passive uh, flexion of the hip, which could lead to impingement of the anterior inferior iliac spine on the femoral neck, pain on rectus stretch, and sometimes one can elicit tenderness at the anterior inferior iliac spine. X-ray, plain X-ray may give a little clue to the diagnosis, but most of the times it is very difficult to visualize the anterior inferior iliac spine. The diagnosis is primarily made by the CT, and in the CT there are three types of anterior inferior iliac spine morphology is described. To remain very basic, it is type 1, where the anterior inferior iliac spine is above the level of the acetabular rim. In type 2, it is at the level of the acetabular rim, and in type 3, it is below the level of the acetabular rim. And the more the anterior inferior iliac spine below the level of the acetabular rim, the more likely it is to likely to cause the symptoms. Again, the treatment could be non-operative in the form of activity modification, analgesics, rest, local heat, and if that does not solve the problem, the treatment remains removal of the impingement, where you could consider arthroscopic or open anterior inferior iliac spine excision with reattachment of the rectus. So that means that prominent part of the rectus, which is abutting against the femoral head and neck region, this part should be excised and is usually required in type 2 and type 3 anterior inferior iliac spine. Type 2, remember, is at the level of the acetabular rim, and type 3 is below the level of the acetabular rim. Next, we come to ischiofemoral impingement. And ischiofemoral impingement is due to reduced space between the ischium and the lesser trochanter there. And this reduced space between the ischial tuberosity and the lesser trochanter, as you can see, leads to friction, repetitive friction in the quadratus femoris. And this is the primary reason for pain in these patients. So clinically, it presents with posteriorly deep-seated pain, which aggravates on walking. The pain is aggravated on hip extension, external rotation, and slight adduction. That means on external rotation, extension, and slight adduction, this LT becomes more near to the ischial tuberosity. And once it becomes nearer to the ischial tuberosity, the impingement increases. And that is the usual clinical test what you perform in these cases. So what are the common reasons? One is after a subtrochanteric valgus osteotomy, and where you are correcting the mechanical axis, that leads to a medialization of the lesser trochanter. The second is an anatomical variant where the distance between the LT and the ischium is less. And third one of the possible sometimes is the osteochondroma of the involving the lesser trochanter, as you see in this particular patient. Most of the times, this and this condition. So anatomical variant of proximal femur leading to deep-seated pain. And this is often missed if you do not know that this sort of impingement can occur. What is the provocative test for this? Pain on hip extension, external rotation, and slight adduction. If you do this maneuver, the pain should increase. How do you confirm your diagnosis? Well, radiographs can give you some clue. If you see here the reduced joint space, you can see here the reduced joint space. But sometimes, most or lot of times in this variety where there is an anatomical variant of the proximal femur or a prominent lesser trochanter, this is very, very subtle. And in those cases, one considers an MRI, and with the MRI, one can see edema in the or atrophy of the quadratus femoris muscle between the lesser trochanter and the ischium. And once you see this, it is indicative of LT ischium impingement. The treatment is primarily conservative in the form of physiotherapy measures, including ultrasonic massage and uh, deep-seated heat modalities like shortwave diathermy, analgesics, and some sort of activity modification of reduced activity. But in cases where it does not solve the problem, which is very, very uncommon, one can resume, one can consider surgery in the form of resection of the lesser trochanter and reattachment of the psoas tendon there, or release of quadratus femoris, which got caught between the lesser trochanter and the ischium. The fourth type of impingement is between the greater trochanter and the pelvis, and it is often the high riding greater trochanter which impinges on the lateral wall of the ilium during abduction. The presentation is again pain in the hip region, exaggerated on cross-legged sitting, means chौकड़ी मार के बैठना, it increases. So that means the pain is exaggerated on flexion, abduction, and external rotation. And in some of the cases, you will find a reduced abduction because the lesser trochanter is impinging on the pelvis and causing a mechanical block of abduction there. So what are the cases where you will have a trochanteric impingement? A coxa breva like this, a high riding greater trochanter, and sometimes in coxa vera along with a little high riding greater trochanter. Something like this. This is a child, but there is an unossified trochanter. And these sort of cases, if there is pain and limitation of abduction, then you should consider a GT pelvic impingement. The treatment basically remains a distal transfer of greater trochanter and its various variations, including uh, the whole transfer of the greater trochanter or a relative neck lengthening or its variations like this. So what you do is take off the trochanter, chip here, resect this part of the trochanter and attach this using a safe surgical dislocation here. And this will give you a relative neck lengthening. And this will solve the problem of the impingement. I do a little modification in the sense that I use this chip of bone here and take a block using a subperiosteal dissection using the safe surgical dislocation. And that will give a little lateralization to the greater trochanter using a safe surgical dislocation approach. So to summarize the extra-articular impingement, psoas impingement seen in footballers, athletes. Most of the extra-articular impingement, the treatment is non-operative initially, but in non-operative fails, then operative by the form of psoas resection at the level of the labrum. Anterior inferior iliac spine uh, 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 impingement is operative in this form of resection of the interior inferior iliac spine if the non-operative measures fail. And both these conditions sometimes lead to early degenerative arthritis due to labral and cartilage involvement. GT pelvic, mostly operative, does not lead to degenerative arthritis. Lesser trochanter and ischium, mostly non-operative. So I can pause here for a moment, and if we have some questions on this extra-articular impingement, I can take it, and then we can proceed to intra-articular impingement. Can we pause here?
Sure, sir.
Yeah, sure.
So I'll
Any
stop
questions?
share from here.
Hmm.
So
Okay, so
any of the residents who have a question?
Yes, Pratyush, Sachin, if you have any doubt, you can ask directly. I think they are yet not ready with questions, sir. So if some question is there from you, sir, you can ask.
yeah, I think that might be better if they don't ask questions. It's better if we ask them questions. So PN, I think we should ask them some questions now. That's the only way they'll start asking questions themselves.
Oh, yeah, I think so. Pratyush,
Yes, sir.
yeah, Pratyush, can you tell me some of the common presentations of the uh, LT pelvic, LT ischial
Sir,
impingement?
the pain on adduction and external rotation.
Yeah, extension, adduction, and external rotation. Yeah.
Yes, sir.
And it's very important that you recognize this deep-seated pain. A lot of times it is confused with pain from other regions, including the sciatic pain, including sometimes, the pain from the SI joint, pain from the back, buttock pain. I mean, this can be confused,
Yes, sir.
right?
Yes.
And another common thing which is I have not covered here is not actually in the impingement area is piriformis syndrome. You heard about this?
Yes, sir.
So piriformis syndrome, how does it present? Pratyush?
Sir, sorry, sir.
Again, it is a deep-seated buttock pain. And once you stretch the piriformis, how do you do that? Flexion, adduction, internal rotation. Flexion, adduction, internal rotation. And if that causes a posterior buttock pain, that is a piriformis syndrome. Anyway, so I think any other questions?
Yes, Amil, you was asking something?
Yeah,
No,
Amir?
sir, I was telling about piriformis syndrome.
All
DD
right.
of deep-seated buttock.
Okay. So should I proceed with the
Yeah, please do it so we can,
particular?
they can sort of make out their questions for the end. Okay, so we expect questions from you at the end of the talk.
All right. Now we come to the more important part of the talk, which is the intra-articular impingement. And intra-articular impingement is much more frequent than what you realize even in the Indian scenario. It is much more commoner in the Western population, but we have started seeing a lot of cases in the Indian scenario as well. So when we were postgraduates, these sort of situations of intra-articular impingement were never discussed as a part of the hip pain. What was discussed were very, very classical things like AVN, tuberculosis of the hip. And unless you know that these can lead to problems of hip pain and early degenerative arthritis, one can easily miss the things. So intra-articular is basically a cam impingement, a pincer, or mixed. Let's see what all these conditions are. But before that, one should know the risk factors. In the congenital risk factors, it is a increased retroversion or a protusio or some alteration in the shape of the acetabulum or some alteration which is elliptical or a little aspherical head. These are congenital or developmental issues in a person. The acquired are because of the excessive range of motion, especially seen in the athletes and gymnasts, where they sort of take their hip to a range of motion which is more than the population average, and that causes a intra-articular impingement. And sometimes it is seen as a sequelae of childhood diseases, including complications of DDH, slipped capital femoral epiphysis, Perthes, and sometimes in malunited fractures of the proximal femur as well as the acetabulum. So age, what we will be discussing is a idiopathic variety or this variety, which is sort of idiopathic variety. So age at presentation could be any age, but most common presentation is between 20s and 40s. Sometimes the presentation could be in a much younger person, especially in ladies, where it can present as early as 14 to 15 years of age as well. The CAM type is more common in men or male sex with ratio of 14:1. And the pincer type is more common in females where ratio is 1:3. What is the effect of impingement? Repeated abutment of the proximal femur and the acetabular rim leads to injury to the acetabular cartilage, the labrum, leading to a progressive joint damage and early degenerative arthritis. The presentation is a gradual onset of hip pain, and lot of times the patient will present with a pain resembling a C. That means anterior, lateral, posterior, deep-seated, vague pain in the hip region. And once you are stressing the hip to extremes of position, like sitting position, squatting position, and sometimes you are stressing the hip due to sports, the pain gets aggravated. Later on, there could be difficulty in getting up from the chair, wearing of socks and shoes, and eventually antalgic gait occurs once the degenerative arthritis sets in. So what are the tests for impingement? You have the anterior impingement test, which is flexion, adduction, internal rotation. FADIR, it is commonly called as FADIR, F-A-D-I-R. Some people call it FADDIR. Flexion, ADD is for adduction, internal rotation. So that means if you are flexing, adducting, and internally rotating, the impingement occurs at the anterior margin. And later on in later stages, because of that impingement, there could be some limitation of flexion and internal rotations. Impingement could be posterior also. And the posterior impingement tests include the Faber test or flexion, abduction, external rotation. And then is a second test, which is where you take the patient to the edge of the examination table, extend the hip, and external rotate in neutral rotation. And if that causes pain, then it is a posterior impingement. And please remember this fatigue test, flexion, adduction, internal rotation, in a patient of impingement should cause pain on the anterior hip region. And if this causes pain on the posterior hip region, that is indicative or suggestive of piriformis syndrome. Now let's see both these CAM impingements and pincer impingement. CAM is an aspherical femoral head at the head and neck junction and usually seen in young athletic males. And once this CAM occurs, this CAM is there. And once there is extreme of flexion, it impinges into the acetabulum and initially causes damage to the articular cartilage and eventually to the labrum, leading to early degenerative arthritis. So initially there is a chondral delamination leading to further cartilage damage at the anterior superior aspect of the acetabulum, and labral injury occurs little later in this group. This is frequently seen after a slip capital femoral epiphysis as well. So imaging will show you a pistol grip deformity, which appears like the handle of the pistol grip. Asphericity at the contour of the femoral head and neck junction. You can appreciate here. You can appreciate here. You can appreciate here. And no, loss of normal concavity. Normally, this area is concave, this area is concave. So loss of normal concavity at the head and neck junction. And this impingement is also seen on the lateral view. And what do you evaluate on the lateral view is the alpha angle, where you make a sphere. And sorry, this figure is not, these lines are not accurate. You draw a line from the center, center of the femoral head in the long axis of the neck. And second line is to the, where there is this bump at the junction of the head and the bump. And if this angle is more than 50 to 55 degrees, this is indicative of a CAM type of femoroacetabular impingement, and it is evaluated on lateral and modified Dunn's views, which are basically lateral views of the hip. There is a beta angle which is described, which is between the acetabulum and the bump, and less than 30 degrees is impingement. I'm not going to go into the details of this. So the junction between the first concavity where you see from the acetabular margin to that first concavity where you see is the beta angle. The treatment remains a resection of the impingement there, and there you can see the resected impingement, which is called osteochondroplasty. And this is usually done if the non-operative management in the form of activity modification fails to resolve the symptoms. But this could be done by a safe surgical dislocation approach, like what I have done here, or with a arthroscopic approach. Pincer. So, anybody who can tell what pincer is? Pincer is this instrument. What is the action of this instrument? It is to take a strong grip on something. And if the acetabulum takes a strong grip on the femoral head, that is a pincer femoroacetabular impingement. So this is a force of the acetabular edge on the femoral head and neck junction. In the CAM, there was a abnormality in the femoral head and neck junction. Here the femoral head and neck junction is normal, but the acetabulum is abnormal. And let's see where these and in extremes, it can impinge here. And because of the leverage action, it can cause a counter-co injury on the posterior inferior cartilage as well, leading to more cartilage injury. A cartilage injury here because of the counter-co effect. So pincer, most common is in the middle-aged females, but you can see in the young females as well sometimes. It is slowly progressive there is a focal articular damage and counter-core injury on the posterior inferior region. So what are the reasons for pincer? One is a global overcoverage, which is seen in coxa profunda and protusio. Acetabular retroversion, and third is a focal anterior superior rim prominence. So coxa profunda, if the head is deep seated, you can appreciate that the acetabulum or acetabular wall will impinge on the head and neck junction. And how do you see the coxa profunda or protusio? Where the acetabulum margin or acetabular fossa extends medial to the ilioischial line. And this basically creates a deep acetabulum with impingement or a pincer-like action on the superior and the inferior aspects. The second is retroversion. Let's see how do you evaluate retroversion. Let's see what this normal radiographs look like. You have the femoral head. You don't have a ischial spine visible in case there is no retroversion. You have a acetabulum where this yellow is the posterior wall and this is the anterior wall. So there is no crossover between the anterior and posterior wall. And the center of the femoral head is medial to this posterior wall. This is called posterior wall sign. And if it is lateral, if it is lateral to the posterior wall, it is called posterior wall sign. So let's see what is there in an abnormal situation, right? So you can see the center of the femoral head is medial to the posterior wall. Okay. So let's see this child aged around 14 or so, where you can appreciate the crossover sign. You can appreciate a prominent ischium there, ischial spine there. You can appreciate the crossover sign, and you can appreciate that the center of the head is lateral to the. You can appreciate this and this. This is a crossover sign. So you can appreciate that the center of the femoral head is lateral to the posterior wall. And these are the three features of acetabular retroversion. How do you see acetabular retroversion? By these three features. What is the prerequisite? The X-ray should be well centered without any rotation of the acetabulum. Then is a focal anterior superior rim prominence, where the sourcial angle, normally it is 0 to 10, and if that reduces, that is a focal anterior superior rim prominence in absence of the other radiographic parameters. If there is an anterior overcoverage, you see the lateral center edge angle, and you can similarly see the lateral center edge angle and the anterior center edge angle. And if they are more than 40 degrees, that is indicative of impingement. Similarly, you draw a line from the center top, draw a line to the lateral margin of the acetabulum, and if this angle is more than 40, that is indicative of overcoverage. CT scan is adjunct to the plain radiographs. And where do you see these CT cuts? Just at the superior margin of the acetabulum, just here, not here. And once you see this anterior wall is more, this coverage is more anteriorly, these are indicative of this. You can measure the anteversion or retroversion on plane, on CT, axial CT cuts. and they guide to the bony resection and exact size and location of the pincer FAI. MRI is not per se useful in the evaluation of FAI, but in some of the cases to see the status of the articular cartilage and labral tears. Like this, you can see the articular cartilage normal on this side, you can see the involved articular cartilage on this side. And sometimes in T1 images, you can also evaluate the bony anatomy as well. And whatever angles you have drawn on the CT, you can draw on the MRI as well in T1 images. Treatment basically remains operative in these cases, but one can consider non-operative if the patient presents very early and the symptoms are very, very mild. But most of the patients, eventually, if you want to preserve the hip, they will end up in a operative procedure where you can do a reverse periacetabular osteotomy for superior overcoverage and acetabular retroversion. And rim resection is done in focal anterior superior coverage, overcoverage. So to summarize the intra-articular impingement, femoral side due to CAM, more common in males, more rapid progression. Pincer type, more common in females, slower progression. CAM impingement, surgical treatment remains osteochondroplasty. Pincer impingement, acetabular retroversion is antiverting periacetabular osteotomy. Coxa profunda, you basically change the angle from to more superior. That means you are making the acetabulum little more upsloping than more downsloping. And focal anterior superior overcoverage is rim section using the safe surgical dislocation approach. So to summarize everything, one has to recognize femoroacetabular impingement as a cause of hip pain. There are various provocative tests. There are various radiographic parameters, including plain radiographs, MRIs in selected cases. Clinical and radiological evaluation is of utmost importance. And most of the intra-articular femoroacetabular impingements are likely to require operative intervention, and lot of extra-articular femoroacetabular impingements, especially the GT pelvic and the psoas, sometimes will require operative intervention. I think I'll stop here. Thank you so much.
Okay, so any questions?
Yes, sir. So how often you take CT scan to rule out intra-articular?
Intra-articular, what?
That CAM lesion and pincer. How often it is required?
Basically, it is the clinical diagnosis coupled with the plain radiographs. CT scan is basically done for surgical planning. Most of the time, you can appreciate coxa profunda, you can appreciate acetabular retroversion, you can appreciate a focal anterior superior overcoverage by these parameters what we have discussed. And if you take standard radiographs, AP, Dunn's view, false profile views, you can appreciate the proximal femoral anatomy better. So CT scan is basically done to fine-tune your surgical resection.
And the role of MRI is also something which is limited to really looking at labral injuries, etc. Okay, so if you want to localize a labral injury and delineate it, then you need an MRI. It's not really at the diagnosis which is made on the MRI.
One of the things which I wish to add here is that there is a MRI which is called delayed gadolinium enhanced MRI, which is degeneric MRI, It started with the evaluation of the articular cartilage of the knee, but now the extension is there to the articular cartilage of the hip.
The hip, yeah.
So what the degeneric MRI tells you is the status of the articular cartilage much better than the regular MRI or a regular contrast enhanced MRI. So it is a delayed gadolinium enhanced. And if you find that the articular cartilage is unsalvageable, in those cases, one should consider the hip sacrificing surgery like a total joint replacement rather than going for preservation if you find the status of the articular cartilage is bad. So that is the role of that's the only role of degeneric MRI.
Yeah, that's in a situation where you're trying to decide whether
Yeah,
you
in borderline
are-
cases
yeah.
where,
But
yeah.
I think the lateral problems are better delineated on the MRI
on
than the
MRI,
other
yeah.
way, yeah.
I fully agree.
So any questions from the delegates or from the DNB students? You are the ones who should be asking questions. Otherwise, Professor P.N. Gupta will be asking you questions again.
Sir, femoral
Yeah, okay, good.
Yeah.
Yeah.
femoral offset. How femoral offset can uh, uh, influence impingement, sir? Change in offset, femoral offset.
You mean femoral offset means what exactly? What do you mean by femoral offset? Offset between what?
Horizontal offsets.
You're talking
No,
about a
offset.
joint replacement or a
In there is a change in head. There is change in head offset. Yeah, offset leading to impingement. Pincer. Yeah, cam
so
is
In CAM, actually, if you see the offset between the head and neck is less.
yes, sir.
So there is a little bump which you can appreciate. If you wish, I can show that again on the radiographs.
So I think offset is something which you can only change by relative length and neck lengthening,
Yeah.
which is not
Lateralization of the GT.
always necessary in these situations. Okay.
So
So
it's
I think-
talking of offset between the head and neck, head and the
Yeah.
GT. Yeah, okay.
Yeah. So that's the only position where you need to change if you're having the GT which is impinging, or if you have a very short neck and you want to distalize and do a relative neck lengthening by
Yeah.
distalizing the trochanter and also getting the length longer, neck length longer. So those are situations where some of the malunions or non-unions
AVN of the neck,
femoral
AVN of the neck,
yeah.
and yeah, a lot of time this is seen in post infective conditions or
Yeah, trauma.
post DDH, post surgical conditions in childhood and
Thank you,
post trauma also. Yeah.
Yes.
So, Dr. Sachin has asked about the role of acetabuloplasty in pincer impingement.
Acetabuloplasty, as I understand, is a term which is used in DDH. So can you clarify this question? Because
Yes, Sachin.
Sachin, can you clarify?
So, so first is, do you understand what a pincer impingement is? It's the
Sachin,
acetabulum.
can you understand? Pincer is this. So if there is a deep-seated head, this is going to lead to pincer here.
So you
Sachin, can you appreciate that my hand?
Yeah.
Normally the coverage is like this.
Yeah.
So deep-seated head, it is pincer here.
So you
Retroversion, let's say this is the anterior side. That's the posterior side. Right? So acetabular retroversion would be more coverage anteriorly. And if you flex, this is going to impinge anteriorly. If it is focal, you resect the rim and reattach the labrum. If it is global, you reorient the acetabulum. Acetabuloplasty is a volume reducing surgery and is frequently done in DDH. So acetabuloplasty has no role per se. It is periacetabular. It is a reorientation.
Yeah, but you can also take off the impingement part by excising bits of the acetabulum or the head, which is
Yeah.
impinging on the thing. Okay.
If it is combined impingement cam and pincer, then you consider tackling both the areas.
Yeah.
Yes.
Okay, so another question asked by Subhanshu is what labral impingement considered in FAI? Subhanshu?
No, can you clarify that question,
Yeah.
please?
Yeah.
Sir, if there is a impingement
Yeah.
due to labrum, like labrum is
Means
labrum
extra-articular area.
is
No,
sir
labrum
intra.
will get caught between the head and neck region, acetabulum and the proximal femur region.
So I think the labrum gets damaged because of the impingement.
Yeah,
Okay?
it gets damaged because of the pinching action between the head and neck, proximal femur and the acetabulum.
Okay. And it could be part of the, in a pincer impingement, obviously, that would be a part of the impingement. Okay.
So I can show them again. I think that will make the things more clear.
The difference between the two.
I think
I think the schematic diagrams you had were
yeah,
very
that
clear.
schematic diagram I can what is happening this. Just a moment.
Share your screen and go back.
Yeah, no, I'll just make it again.
Okay.
Let me go to those slides. Yeah. So let me slide share. Okay. So can you see here? I'll go back. Can you see here? So this is the normal, this is how the normal, this deep yellow thing is how the normal head and neck should look like. And this light yellow thing is what, there is an extra bone there. So it looks like a cam or a aspherical thing. And once there is a flexion there, you can appreciate this area of the head and neck junction is going to go into the acetabulum area. So this is going to impinge into the acetabulum and cause a damage to the cartilage there and later on to the labrum. Is it clear?
Yes, sir.
Now, second impingement is the pincer. Pincer, this instrument is called pincer. So pincer means to pinch. So how it will pinch? You can appreciate if the head is deep seated like this because of the protusio or coxa profunda. Okay. This is going to impinge here. This is going to impinge here. This is over coverage. And if you see this acetabulum, can you appreciate this acetabulum? It is a shade upsloping. Can you appreciate that?
Yeah.
And if you see this acetabulum, this is downsloping. Can you appreciate that? This is a downsloping acetabulum. This is a upsloping acetabulum, and this angle between this sourcel, you know, is this white part, is 0 to 10 degrees. And here, if you see, this is a reverse sourcil. It is -10 or -12 or so. And this is,
Yes, sir.
it should be 0 to 10 upsloping, horizontal or upsloping 0 to 10. And if it is downsloping, then this will cause impingement. Okay, this is one reason for impingement. Second is a retroversion. Retroversion means the acetabulum is retroverted. That means there is more coverage anteriorly and less coverage posteriorly. And if there is more coverage anteriorly, and once you flex it, the proximal femur is going to impinge on the acetabular margin. Right? How do you see that? By crossover sign. And this ischial spine sign and the posterior wall sign. Okay.
Okay.
And third is a focal coverage. Focal coverage where you can see this downsloping acetabulum again, and you can appreciate, you draw a center edge angle and it is more than 40 degrees, more than 39 actually, but you can remember 40 degrees. So that is over coverage.
Okay, great. Thank you very much, Dr. P.N. Gupta. That was a very lucid talk, which really should have clarified all the doubts people may have about this subject, which is not that well known as yet. And it's great to have you here, and we'll be happy to have you again in future talks. Okay, so great. Thank you very much. Oh, there's someone asking you about done view. So last question before you go.
Done view. I think it's actually a view where it's a sort of a lateral view. And what you do is usually, it is more useful in the OT where you want to take a lateral on a regular table where you flex the hip to 90 degrees or 45 degrees, whatever position you want. The 45 degree done, 90 degree done, and you abduct the hip about 20 degrees or so. And then you take a AP view of the thing, and that will give you a lateral view of the femoral neck.
Great.
That's a Dunn's view. There are a lot of modifications of the Dunn's view. You can go through that in the literature.
Okay, great. Thank you very much, Dr. P.N. Gupta. And as I said, it was a very well-planned and lucid talk, which really should have clarified many doubts. And like I said, we would hope to see you again in our future
it will be
talks, and it will be a pleasure. Okay, great. Thank you very much. And bye, everybody. Okay.
Thank you very much, sir.
Sure.
It was great.
Thank you, sir.
Yeah. Thank you, sir. Thank you very much.
Thank you, sir.
Yes.
Thank you, sir.
Thank you.